Welcome back to Polymeric Biomaterials. We have been looking at the theme of surfaces and interactions, and that's the theme we are going to continue today as well. In the past, we have looked at protein adsorption in the previous lecture under this theme, and in some sense we will continue that theme today by looking at blood interactions with biomaterial surfaces. Now, it will help if you think of this as one sequence of temporally spaced out events where when a biomaterial is implanted, protein adsorption occurs first, followed by blood interactions, and then will come immune response, inflammation, foreign body reaction, etc., which we will look at in the next lecture. So, this lecture will serve as a bridge between the protein adsorption lecture and the next lecture where we are going to look at inflammation and immune response. So, with that little bit of background, we will take a quick look at what we will see in today's lecture. We will start off with an overview of blood components and the clotting process itself and why it is important to study clotting. We will look at some terms that are related to understanding hemocompatibility and blood material interactions. Then we will look at specific aspects related to coagulation, thrombosis and hemostasis, and what factors govern that delicate balance between something that can lead to a clotting disorder versus a bleeding disorder. And we will focus quite a bit thereafter on platelet responses, which are the key drivers in coagulation and the cascade thereafter, as well as the key players involved in the blood coagulation cascade. Then we will look at how clot is resolved and look at some strategies to prevent clots. And towards the end of this lecture, as always, given that our focus is biomaterials, we will be looking at design of anti-thrombotic surfaces with specific reference to heparin and heparinization, and at the end we will deal with one particular problem that can occur with blood contacting devices over time, namely pathological calcification, and why we should guard against that and be careful when we design materials. So, with that overview, let us jump right into today's lecture and first look at the components of blood and their functions. So, this is only a very broad bird's eye view of the components present in blood. Blood is about 44% by volume red blood cells, erythrocytes, and you have plasma making up about 55% by volume, which contains proteins, sugars, hormones and clotting factors, and less than 1% is white blood cells and platelets, although they play an extremely important role, as we will see in today's lecture and the next lecture, in dictating the responses of the host to implanted biomaterials. Now, very briefly, these are some of the primary cell types found in blood and their key functions. Red blood cells, for example, are primarily involved in transport of gases apart from other functions, essentially transport of oxygen and carbon dioxide. These cell types, neutrophils, eosinophils and basophils, these are all what are broadly called granulocytes. They are a part of the WBC system. They are a type of white blood cell, and they do multiple functions. For example, neutrophils typically will guard against invaders and phagocytose them. That is one of their primary functions. Eosinophils will combat parasites or parasitic attacks. Basophils are more involved in mast responses, allergic inflammation and so on. Apart from these, you also have two other types of white blood cells, namely monocytes or more specialized forms of monocytes called macrophages, which we will have a chance to look at in the next lecture, as well as lymphocytes, T and B lymphocytes, which are memory cells that are involved in the adaptive immune response, which are also very important when we look at biomaterial interactions in the host. So, that is a quick overview of the different types of cells present in blood and their broad functions. Now, one specific aspect of blood interactions that we are going to look at in today's lecture in some detail is the role of platelets and how they contribute to clotting. So, this is just a quick overview of what platelets are and how they function as far as clotting is concerned. Platelets are essentially non-nucleated, disc-shaped cells or essentially cell fragments, and because they do not have a nucleus, they cannot reproduce, so they have to be continuously produced by the body, and they have a host of different functions. But because our goal here is primarily looking at blood material interactions, we will focus on their role in promoting plugs during injury and then initiating the coagulation cascade. So, some of the functions are listed here for platelets. One is they secrete vasoconstrictors as the immediate response to injury to reduce blood loss at the injury site, and then once they can sense that there is an injury, they are able to attach and get activated by attaching to the injured vessel, and then can arrest the bleeding by forming what are called platelet plugs, the mechanisms of which we will look at in some detail in this lecture. Some of these platelets thereafter can bind together by bridging, enlarge the plug and then initiate the coagulation cascade. Now, shown here is a quick schematic representation of that process, highlighting the key steps involved. So, if there is an injury where the blood vessel is injured, the components, primarily white blood cells, erythrocytes, platelets, etc., they leak out, and that is what is shown here. And then the vessel contracts, and that is called vascular spasm here near the injury point. This is to prevent loss of blood, right. And then the critical role of platelets come in, where platelets form a plug to seal off that region, so to speak. So, platelets are activated by either chemicals that are released from the injury side, or by direct exposure to proteins in the extracellular matrix like collagen, for example. And once they are activated, like we just said, they can stick to these injured surfaces and start to seal off the injured surface by forming a platelet plug. And in the context of biomaterial implantation, just the fact that there is surgical procedure involved in implanting a biomaterial in the body means that there is going to be injury to blood vessels, and hence many of these biomaterials that we have discussed in this course so far will come in direct contact with blood, and therefore it is very important for us to understand blood material interactions as far as the body is concerned when a biomaterial is implanted. So, that is the context for this lecture. Now, before we proceed further with understanding some of these mechanisms, it is useful if we can pause for a minute and understand some terms that you will commonly come across when you look at hemocompatibility or blood material interactions. One of them is coagulation, the other is hemostasis. Now, coagulation is a regular routine bodily process by which the body prevents blood loss. This is, if you happen to injure yourself, coagulation is going to happen, it is going to form a clot. This is to prevent further blood loss. So, like I said, the clot is formed starting with platelets, which lead to platelet plug, leading to coagulation cascade, leading to formation of the clot. This process of coagulation is typically seen in a normal wound healing response. When you have an injury, this is typically seen and it will resolve over time. And a closely related word that you will hear often is hemostasis. This is sort of an umbrella term that describes the delicate balance between processes that form clots and processes that dissolve or resolve clots. So, essentially this describes a series of steps or a series of coordinated steps which work together to first form the clot in response to an injury and then subsequently dissolve the clot once the wound healing has occurred. So, it largely involves 4 steps. First is the vascular constriction, as we saw on the previous slide, which limits the blood flow to the site of injury, followed by platelet activation, which leads to a platelet plug that covers the injured site. Then the coagulation cascade is initiated, which leads to the formation of a fibrin mesh or a clot which encapsulates the platelet plug, and eventually the plug or the fibrin clot has to dissolve for the normal tissue function to resume. So, that set of processes that are involved in forming and resolving a clot, and the balance between them is what is called hemostasis. Now, this is typically what you would see in regular normal wound healing in response to an injury. But you can also have something called a thrombus formation through a process called thrombosis. Now, this is often used interchangeably with a clot. Thrombus and a clot are often used interchangeably, although we are making a subtle difference here. For us, a clot could happen like we have just said in the course of a normal injury, but thrombus formation typically in the context of biomaterials, for example, is usually associated with pathological mass that forms within the blood vessels in response to an implanted biomaterial that comes in contact with blood. So, this is again more of a broader term that is used to describe the fibrin clot with the entrapped platelets, red blood cells and the white blood cells. And thrombus formation can be quite problematic, although it is very difficult to avoid thrombus formation with implanted biomaterials. Thrombus formation can be quite problematic because it can potentially obstruct blood flow through the vessels, it can occlude the vessels, and more dangerously over time these clots can break off and travel to other regions of the body, and depending on where they go, they can cause stroke, heart attacks or even pulmonary embolism. Now, these can have life-threatening consequences. And shown on the right is that balance that I talked about for hemostasis, where on the left hand side you have imbalance leading to a bleeding disorder or a set of bleeding disorders, and on the right you have a set of factors that promote thrombotic disorders, and the delicate balance between them is what leads to normal hemostasis. So, for example, if there is decreased coagulation or increased fibrinolysis, which is essentially the process of clot dissolution, or if you supply coagulation inhibitors from outside and that is an excess, all of that is going to reduce the ability of the blood to coagulate, and that is going to lead to bleeding disorders potentially if not done correctly. And sort of the inverse or the converse is true when you look at thrombotic disorders, where there is an increase in coagulation, there is decreased fibrinolysis, so even the clots that are formed are not easily dissolved, and of course this can occur if a patient, for example, is taken off coagulation inhibitors too soon, right. So, this balance is what the body aims to achieve, and the implantation of a biomaterial unfortunately will almost always result in thrombosis. So, one of the large goals of biomaterial design, although that has not been achieved till date very successfully, is to prevent or at least minimize thrombosis to the maximum extent possible, because excessive thrombosis can have very devastating consequences for the patient. Now, once we have understood that that is one of the goals of biomaterial design, we can also now see why it is important to study blood material interactions by looking at specific examples of blood contacting devices. Now, shown here are all devices and the respective polymers that are used, where many of these devices use these polymers, and many of them will get implanted or at least will come in contact with blood, catheters, pacemakers, vascular grafts, heart valves, extracorporeal oxygenation devices, dialysis membranes. So, these are all examples that we have seen in different contexts throughout this course, and we have in earlier lectures on synthetic biomedical polymers taken very specific examples of some of these devices and looked at the role of some of these polymers and their structure property relationships guiding their use in such devices, right. So, this is just to drive home the point that understanding blood material interactions and hemocompatibility is extremely crucial because of the involvement of many of these polymers in these devices that directly contact blood when implanted. And as we have already hinted, the inherent response to a synthetic or a foreign material, right, upon contact is for the host to activate the host defense system, leading to coagulation, thrombosis and potentially serious outcomes, right. And therefore, from a biomaterial design perspective or an engineering perspective, new device development continues because of the risk of thrombosis and thrombotic emboli to brain and lungs. This is the thrombus getting dislodged from the blood vessels and traveling to other places, and the continual need for patients undergoing such implantation to regularly be on anticoagulant therapy after implantation. Now that again, you can, as you can imagine, may not be good because it can have systemic side effects. As we saw that hemostasis involves a delicate balance between bleeding and thrombosis. So if you are on continual, if you continually use anticoagulant therapy, that cannot be very good because you will have excessive side effects systemically. So due to these reasons, engineers are continually interested in designing better and better materials that show very minimal thrombus formation and show good quote unquote biocompatibility when they interact with blood. Now, having looked at the importance of blood material interactions, we can also now look at the factors that affect hemocompatibility, and we begin by noting that thrombosis remains an unsolved problem as on date, which means there are no effective strategies to completely obliterate this phenomenon, especially for synthetic materials used in blood contact applications. So the goal is to minimize thrombus formation, because remember, this has to be connected to inherent response of the host in response to implantation. So the host is going to respond in this manner, leading to thrombus formation. Our goal as a biomaterials design engineer is to see if we can come up with design principles that minimize thrombus formation. And there are broadly three aspects that contribute to hemocompatibility. One is the blood, other is the material, the other is the flow. Blood factors include donor health, gender and age of the blood, reactivity of the individual, and any previous drug history, especially anticoagulants, examples of which we will look at later in this lecture. From a material perspective, this again has been the theme of the course. We have looked at quite a bit at the role of charge, hydrophobicity and functionalization of materials in promoting or suppressing specific kinds of biological responses. And in this case, the type of biological response that we are interested in is both platelet attachment and thrombus formation. How can we minimize the thrombus formation through intelligent biomaterial design? And of course, flow characteristics will play a role because this is not a static system. So transport of proteins in cells to or away from the material surface through diffusive and convective mechanisms needs to be accounted for, and forces, particularly shear forces acting on the thrombus leading to detachment, right. If they are small and if the rates of formation and detachment are balanced such that they can be cleared away rapidly, then that is not a problem. But if large pieces are formed that can get dislodged, then that can lead to emboli. So you see that there is a very delicate balance that needs to be struck between the processes that are involved in normal, regular homeostasis. Now that we have looked at factors affecting hemocompatibility, let's dig a little bit deeper into the mechanisms of platelet adhesion, activation and aggregation, all of which are very critical in mediating the initial responses to biomaterial implantation. So the first set of steps involves adhesion and activation. So these platelets have membrane bound receptors on the surface that can mediate platelet surface interactions when they come in contact with specific factors such as the von Willebrand factor or collagen at the site of injury. Now von Willebrand factor is one of the factors found in blood, and collagen is often exposed. Collagen is an extracellular matrix protein, as we have seen earlier, which can get exposed at the site of injury, and blood can directly come in contact with that. Nevertheless, once the platelet circulating in blood comes in contact with factors such as the von Willebrand factor or collagen, then platelets get activated. They can attach and get activated. The von Willebrand factor is an interesting factor because it acts like a double-sided tape, if you will. Right? On the one hand, on the one side, it can attach to collagen when it is exposed, and on the other side, it can attach to platelets. Right? So, it acts like a double-sided tape in that sense. You can also have adsorbed proteins on biomaterial surfaces that can also initiate platelet attachment and activation through integrin binding. For example, here it is through glycoprotein 2B3A, which is actually an integrin. And we note here the role of fibrinogen, which we have seen in the previous lecture, lecture number 31, where we talked about its role in platelet adhesion. Here we are looking at some details of that process. So, fibrinogen has two receptor binding sites that permit platelet bridging and plug formation. So, not only does it help bind platelets, it can also help bridge across platelets. Now, one very important thing to note is the role of conformation, both of the fibrinogen and of the integrin that is found in the platelet membrane. Now, we noted already that the conformation of the adsorbed protein is very critical in promoting binding, attachment and activation of the platelet. So, that is as far as the fibrinogen is concerned. Now, that is also true for the receptor or the integrin found on the membrane of the platelet. So, resting platelets, essentially platelets that regularly flow through blood, do not bind these free proteins in circulation. For example, they do not bind von Willebrand factor, which is also found in blood, or any of these other proteins as they normally flow through blood. This binding occurs only after platelet activation, which causes a conformational change in the integrin or the receptor. So, it is very critical to note that these processes of platelet attachment, adhesion and activation are initiated only when there are these signals that make these proteins, either the proteins like fibrinogen or the receptor, undergo conformational changes that leads to favorable platelet binding and activation. Now, once the platelet is activated, it results in a shape change and results in the extrusion of platelet contents into the extracellular space. Now, these contents that are extruded into the extracellular space are a bunch of factors that cause aggregation of platelets by attracting other platelets to the site, leading to a primary platelet plug with fibrinogen bridging. So, the key aspects to note here, just to summarize, are the exposure of these platelets to and von Willebrand factor to collagen or ECM proteins such as collagen, which leads to platelet binding or adhesion and activation, and the fact that you can have specific, in the case of biomaterial surfaces, you can have specific proteins that can bind platelets and activate them. In either case, activation results in a shape change in the platelets, leading them to extrude a bunch of factors into the extracellular space. That is going to lead to more platelets being attracted to the site of injury to bridge and form the primary platelet plug. Now, before we move on to the next set of steps, which is actually the coagulation cascade, we will take a quick look at the role of fibrinogen from depletion studies which we have seen in lecture 31. So, now would be a good time to pause and recall the role of fibrinogen in platelet binding and the Vroman effect that we saw in lecture number 31 under the topic of protein adsorption on biomaterial surfaces. So, essentially what we want to point out here is if you have fibrinogen pre-coating on surfaces, you can have platelet binding. And what happens here is if you have surfaces pre-adsorbed with plasma that is deficient in fibrinogen, the platelet adhesion to such surfaces is much less than to the same surface pre-adsorbed with normal plasma containing fibrinogen. And this is again something we have seen in lecture 31, and we noted that this platelet binding ability can be restored to these surfaces that have been pre-exposed to plasma deficient in fibrinogen through the exogenous addition of fibrinogen, right. Platelets can now start binding. So, that tells you the critical role of fibrinogen in promoting platelet binding and activation. Interestingly, removal of fibronectin, vitronectin or von Willebrand factor from plasma has little effect on platelet adhesion in some of these studies, because competition from fibrinogen and other proteins keeps the surface concentration of these other proteins very low. Although on their own in pre-adsorption studies, proteins like fibronectin, vitronectin etc. perhaps can promote platelet adhesion, their removal from mixed protein solutions still has not much of a significant effect, because it is primarily through fibrinogen that platelet adhesion is mediated. The reason we are looking at this is to understand the role, importance and limitation of these controlled in vitro studies. So, while they do provide a lot of insights into mechanisms, rates, etc., they are limited because ultimately the real acid test, so to speak, is direct implantation in a host such as an animal or a human being. So, there the mechanisms that act are very different compared to the mechanisms that occur in controlled in vitro microenvironments. They are both important for very different reasons. So, it is good to sort of understand the context whenever you come across such studies. It is good to understand the context in which these results must be interpreted, so as to not get too carried away by overemphasis on one particular mechanism as compared to the other, because the host has many other compensatory mechanisms which are typically not seen in controlled in vitro microenvironments. But still, in such controlled in vitro studies are important for us to tease out mechanisms, particularly depletion studies, the details of which again we have already looked at in lecture 31. We are only recapitulating some key aspects. The take home again from all of this is that platelets can get activated, can attach and can get activated in response to an injury, or when they, especially when they come in contact with factors like collagen and von Willebrand factor together, or through pre-adsorption or adsorption of specific types of proteins on the biomaterial surface, right. Now, that is one of the first key steps that occurs when these devices come in contact with blood. Thereafter is initiated a series of steps known as the coagulation cascade, and this is a fairly complex and very involved mechanism. Essentially, we note that there are two primary mechanisms for thrombus formation during BMI. This is what will ultimately lead to a thrombus when it comes to blood material interactions, right. That is what BMI is. One is the platelet aggregation mechanism, where coagulant activity is initiated, as we will just see in a minute. Thrombin burst on activated platelet stabilizes the initial plug, right. There is another mechanism that can potentially act, which is contact activation, called surface contact here, or the intrinsic pathway, which has to do with the adsorption of specific types of proteins found in blood, namely factor 12, factor 11 etc., onto material surfaces when they come in contact with blood, right. Because our interest here is more platelets, and we have been looking at platelets, we are going to focus on the platelet aggregation related mechanism, although these two will eventually merge in a common pathway towards the end, as shown in this diagram. And what is shown in this table is all the factors that are involved in the blood coagulation cascade. And one question that might immediately come up in a student's mind is, am I expected to remember the names of all these factors and understand or remember all the steps involved in the coagulation cascade? The answer is no, because these are all names and facts that you can look up in a textbook. What I want you to take away from something like this is two things. One is the complexity of the process involved and the number of factors that are involved in something as critical as thrombus formation. And secondly, even if we do not want to remember and recall all the steps, there are some critical steps that are very, very important for us to focus on, especially with the involvement of platelets. And that is what we are going to be looking at, and that is something that would be good to sort of understand, and because that is going to help you also to design biomaterials that can minimize thrombus formation. So, with that, that being our interest, we will now quickly look at some of the later steps involved in the blood coagulation cascade. Although for somebody in the audience who is more biologically inclined, the full pathway is given here. So, you can look up the different factors and try to understand the role of each of those factors in promoting the blood coagulation cascade, resulting finally in the fibrin clot here. But we will only look at some of the key steps involved here. So, one of the key steps again from a platelet perspective is a platelet secreted factor 5 which is activated by thrombin, and this is sort of a positive feedback loop, and that is what I mentioned here, called a thrombin burst. This acts as a positive feedback loop. Essentially, the platelet secreted factor 5 is activated by thrombin secreted by the platelets, and that leads to more thrombin, as we will see, and that keeps feeding back, leading to a thrombin burst, and it turns out is a very critical step for the coagulation cascade, resulting in a thrombus formation. And 5A, which the A simply indicates the activated form of factor 5 here, happens to be a cofactor for 10A. 10A is this in the activated form. So, the 5A and 10A together form a complex which converts 2 to 2A, essentially prothrombin to thrombin. And this happens on the platelet surface. So, that is sort of what is indicated here. And then 2A cleaves soluble 2A, which is the active form, which is the thrombin, cleaves soluble factor 1, which is fibrinogen, into insoluble fibrin monomers, which then polymerize to form long fibrin fibers, resulting in a basic weak clot. Essentially, platelet secreted factors are activated by thrombin and in turn produce thrombin from prothrombin on the platelet surface, and the thrombin that is formed is able to now cleave the soluble fibrinogen to form insoluble fibrin monomers, which again polymerize to form long fibrin fibers, which forms the basic clot, but it is still not stabilized. In the last step, this fibrin clot is stabilized by factor 13 being activated, which covalently cross-links the fibrin chains to result in a stable insoluble fibrin clot. So, the key steps involved are as follows. Platelet secreted factors engage in a positive feedback loop to produce more and more thrombin in what is called a thrombin burst that occurs on the surface of the platelets, and then that thrombin is now able to cleave fibrinogen, which is soluble, and convert it into the insoluble fibrin monomer, which polymerizes into long strands of fibrin, which forms the basic clot, and then that is in turn covalently cross-linked and stabilized by the activated form of factor 13, which is simply the fibrin stabilizing factor. So, in this one slide we have been able to capture some key aspects, and what I would encourage you to do is connect the factors mentioned here to the factors mentioned in this table to the key steps involved in the blood coagulation cascade. So, this should give you a sense of how platelet activation eventually results in the formation of a clot. Now, we mentioned two factors here. One is just platelet aggregation, other is the contact activation. The former is more commonly seen, but in the case of biomaterials, they are both important. While we are not getting into the biological details of each of these steps, because that is not the goal of the course, It's good for you to know that there are different pathways. It's also good for you to know that there is something called an intrinsic or an extrinsic pathway which eventually meet in a common pathway. And for the more, like I said earlier, biologically inclined folks in the audience, you can always go look up these details if you are so interested. Now, where does this leave us? We have now activated the platelets, they have aggregated, they formed a fibrin, they formed a platelet plug and eventually led to a fibrin clot. Now, eventually in normal wound healing responses, this clot has to be dissolved, and clot dissolution occurs by plasmin, which is initially present in the inactive form plasminogen, which when it contacts a clot gets activated by plasminogen activators and converts to plasmin. So, plasminogen with the action of plasminogen activators gets converted to plasmin, which eventually degrades the fibrin in a process called fibrinolysis, right. That degrades the fibrin clot completely, that restores the normal tissue functions. But when you have biomaterial implantation, this sometimes does not happen, right. So, you can have localized thrombosis that can enlarge, or you can have thrombolytic emboli that get dislodged, as we have seen earlier, and a lot of that is prevented externally through the supplementation of anticoagulant therapy. So, that is sort of what we are saying here when we look at how is large scale clotting prevented. Enzymatic reactions, we note, are catalyzed only on an injured surface, right. As we have seen, blood flows freely through the blood vessels, it does not clot on its own. Only in the case of an injury are all those enzymatic reactions that we have seen on the previous slide initiated. And any little clots that form, the blood flow dilutes the concentration of clotting factors to prevent large scale clotting, and that is why flow becomes important, right. So, now you can understand why in vitro studies under static conditions without flow can give you certain types of results, but it is very difficult for you to extrapolate them to understand the role of clots and thrombosis in real life in vivo scenarios. Of course, when there is biomaterial implanted, you have to have coagulation inhibitors, drugs, or from a design perspective, you can also have anti-thrombogenic molecules such as antithrombin 3 that get activated because of heparinization, and we will look at that in just a bit. And shown here is a schematic of the different strategies that are used typically to block different targets in the blood coagulation pathway. The red dotted lines with the hyphen at the end simply indicate that these drugs can block those factors. So, warfarin is very commonly used. There are direct thrombin inhibitors, heparin of course is used quite a bit, and then there are factor 10A inhibitors. So, all of these target different aspects of the pathway, blood coagulation pathway, and that can reduce coagulation in what are broadly called anticoagulation therapies. Now, we have sort of painted thrombosis as sort of a villain, and while there is some truth to it, the more correct way to think about thrombosis is to think about thrombogenicity of biomaterials as a rate parameter, and this is sort of an interesting way to look at it, because if we have resigned to the fact that thrombosis is going to occur no matter what, it's low rates of, if it is low rates of thrombosis, it is typically tolerable, because there are intrinsic fibrinolytic clearance systems that exist within the body to remove these basal levels of thrombosis that occur at low rates. But rates that are sufficient to occlude flow paths in medical devices or worsen surface outcomes are the ones that are problematic, right. So, thrombus formation per se is not problematic when it can interfere with the surfaces of biomaterials when it becomes very large, or when it can occlude or stop blood flow within blood vessels. That's when it becomes problematic, and typically, like I have already said, those are usually avoided after surgery through supplementation with drugs that reduce thrombosis. Now, one thing I would encourage you to pause and look up right now is we have looked at chitosan earlier, and we have looked at it in the context of hemostatic dressings. If you remember, Hemcon that was used in the Iraq war as bandages that could immediately prevent blood loss through specific mechanisms. Now, one thing I would like you to pause and look up is how does chitosan exert its effects? Is it through the cascade that we have just seen? If so, why does chitosan do that? And I have already hinted here that it is not the usual coagulation cascade that I have just described here. So, that should perhaps intrigue your interest because chitosan is something that we have already looked at. It is a polycation which with potent mucoadhesive properties. It can also serve in as hemostats to stop blood from flowing or immediately clot blood, but the mechanism, as it turns out, is quite interesting, and it does not directly have to do with the coagulation mechanisms that we have seen here, but rather it is a charged based mechanism. So, I would encourage you to pause at this moment to look at why chitosan serves as a good material for immediate or rapid clotting and to prevent blood loss in injuries. Now, that we have a good understanding or reasonably good understanding of how platelets get activated and thrombus formation occurs, we can now start to think about, from a biomaterial or a design perspective, how to design non-thrombogenic surfaces. And we note that non-thrombogenic surfaces have to do both with low amounts of platelet adhesion and low activation. Before we look at strategies, there is a very interesting historical perspective here that I want to point out. Now, this is from a paper in 1973. The paper is actually titled "Water as a Biomaterial." It is a very interesting paper where the role of interfacial free energy between blood and the vascular endothelium is discussed. So, it turns out that the vascular endothelium, the endothelial cells lining the inner wall of blood vessels. So, blood vessels have these multi-layered structure, and the inner walls of the lumen is lined with these endothelial cells. And it turns out that blood lining itself, because of the factors that these endothelial cells can secrete, serves as an antithrombotic surface. And it was noted that the interfacial free energy between blood that is flowing and the vascular endothelium is 0, so or is near 0. So, the contention was that any material surface that can sort of quote unquote mimic this behavior will likely have very minimal thrombogenicity. And indeed, materials with minimal interfacial energy with water, for example hydrogels, do not strongly support protein adsorption, cell adhesion and thrombus formation. And again, these are some aspects, the role of water, etc., and how the retention of a hydration layer can prevent protein adsorption. These are all concepts we have looked at in the context of antifouling surfaces in lecture 31, which would be now good to pause and recall. So, having noted that the intrinsic vascular endothelial layer within the blood vessel itself serves as a good anti-thrombotic surface, we now move on to looking at some strategies from a biomaterial perspective that can help towards the design of non-thrombogenic surfaces. One is, of course, directly from the preceding discussion, is to prepare hydrophilic surfaces with coatings with hydrophilic polymers such as PVP. For example, in catheters, apart from increasing the antithrombogenic ability of the surface, this also increases the lubricity for easy catheter insertion, right. From a practical perspective, from a surgical perspective, it makes the catheter insertion also easier. The other usual suspect, of course, is peg chains, which we have repeatedly seen throughout this course, and them grafting onto surfaces with at specific densities, giving rise to specific conformations that lead to resisting protein adsorption due to a number of reasons, including entropic repulsion, static repulsion, osmotic repulsion, excluded volume effects. These are all things we have seen again in lecture 31. A closely related idea is something that I would encourage you to pause and look up, and this has to do with structure property function relationship in the context of PEG. It turns out that the molecular weight of the PEG chain that you are grafting onto a surface, right, is going to have an effect on its ability to effectively resist protein or platelet adhesion. So, if you have two chains that are very short, right, that is not going to be effective because these proteins etc. can still find their way through. If you have very long chains, it is very difficult to pack them tightly, but so it may seem that medium sized chains may be beneficial, but it is also been shown that apart from the chain length, the grafting density also plays a very important role. So, even if you have short chains, if you can graft them very close to each other with a very high grafting density, that is actually shown to be the most effective in many cases. So, there are two aspects that we are looking at here. One is the role of molar mass, the other is the role of grafting density and its relation to chain conformation on the surface. So, these together are structure property leading to function and performance, which is the ability of these chains grafted on the surface to resist protein or platelet adhesion. So, this is something that I would encourage you to pause and look up, essentially the role of PEG molecular mass on protein platelet adhesion, noting that it has to be understood in the context of a grafting density as well. Now, another sort of interesting observation that is often seen with drug eluting stents in the context of thrombogenicity is, if you remember, drug eluting stents are stents that will directly come in contact with blood. These are stents that whose function we have looked at in earlier lectures, that are used to clear out or move away plaques, fat or lipid deposits occluding blood vessels and stopping the blood flow. So, the catheter is inserted on a balloon, the balloon is the balloon is inflated, the stent expands and is now lodged into the wall of the blood vessel and pushes the plaque away, thus restoring blood flow within the blood vessel. One common side effect or one common post-operative issue that can crop up is wrist stenosis, where smooth muscle cells, that is one manifestation of wrist stenosis, can proliferate excessively and again occlude the blood vessel and stop blood flow. But one way to overcome that is to use drug eluting stents, where not only are you taking care of the plaque by putting in the stent, but also this stent has a polymer coating which is going to release a drug over time, that is going to have anti-proliferative effect on these cells. But it turns out that while these drug eluting stents do reduce wrist stenosis, they can increase the risk of late thrombosis, especially a month or two after implantation. And the effect is sort of interesting because drugs like paclitaxel and sirolimus that are typically used in these applications can also inhibit re-endothelialization. And remember that the endothelial cells that line the blood vessel are one of the key players in creating a anti-thrombogenic surface. So, if these drugs are anti-proliferative, they will delay or hinder or even prevent in some cases re-endothelialization of the inner lining of the blood vessel, thus creating a pro-thrombotic environment at the site of stent implantation. So, this is an interesting aside, but nevertheless, because it is related to thrombogenicity and biomaterial design, we are looking at that this example in this context. Now, moving on to other functionalization strategies, and one very common functionalization strategy that is used for preparing antithrombotic surfaces is heparinization or heparin-functionalization. Again, this is something that we have looked at when we looked at natural biomedical polymers in lecture number 20. We saw heparin structure property relationships, and then we saw how heparin can be used to functionalize surfaces to reduce thrombus formation. Essentially, we are just recapitulating some key aspects here. Shown here is the structure itself. You notice right away that there is a high negative charge due to sulfate and carboxyl groups, which leads to a lot of water binding, which we have already seen can have its own impact on protein adsorption and platelet adhesion. The anticoagulant action nevertheless comes from the ability of heparin to bind and activate a natural inhibitor of this called antithrombin 3. Essentially, antithrombin exists in the body naturally, but and once antithrombin binds to thrombin, it is going to make thrombin inactive. And remember, thrombin is one of the key factors that has to get activated to cleave the fibrinogen, as we saw on the coagulation cascade, to lead to the fibrin clot. So, if thrombin is inactivated, then the rest of the coagulation cascade is not going to proceed. And it turns out that antithrombin will not continually bind to thrombin, because that can also be bad, then clotting will never happen. So, antithrombin has to bind to thrombin only under certain conditions, and those conditions can be favorably created by heparin functionalization. Essentially, heparin has a pentasaccharide sequence like so, which can bind to what we call a heparin binding domain on antithrombin. Now, once the heparin pentasaccharide sequence binds to the antithrombin, that leads to a conformational change in the antithrombin. Note that without this conformational change, thrombin will not bind to antithrombin. So, only when the heparin binds to the antithrombin does the antithrombin undergo a conformational change, leading now to the active thrombin binding to the conformationally active antithrombin, and this thrombin antithrombin complex is formed, which essentially inactivates thrombin, leading to arrest of the coagulation cascade. So, you see the sequence of steps that are involved. It is very critical to note that only under specific conditions will heparin bind, will antithrombin bind to thrombin, and that can be mediated through heparin mediated conformational changes in antithrombin. Just as we saw that platelets can get activated only when they come in contact with von Willebrand factor and collagen, which are exposed during injury, right. So, the body has found mechanisms to prevent these things from happening naturally and initiating these processes only under certain conditions. So, this is the mechanism through which heparin's functionalization can make surfaces thromboresistant. Now, one interesting aspect from a structure property function perspective is the role of molar mass of heparin in its activity. Now, it turns out that there are two types of binding sites on heparin. One site binds to antithrombin 3 like we have just seen with higher affinity, and to platelets with lower affinity. So, heparin can also directly bind to platelets, and the second site binds preferentially to platelets, right. So, you note that probabilistically speaking, there are more sites that can bind to platelets, and that is typically what happens in high molecular weight fractions. When you have high molecular weight fractions, because of larger number of sites, these heparin molecules offer plenty of sites for primarily platelet binding, regardless of the presence of antithrombin 3 binding sites. So, it turns out that the lower molar mass fractions are actually more effective anticoagulants. So, again, a clear case of structure property function performance relationships that highlights the role of both structure and property dictating the function and performance. So, this is a very widely used clinical strategy, heparin functionalization, for creating non-thrombogenic surfaces, and broadly they can be classified into three with their own pros and cons. One is of course heparin releasing surfaces. These release heparin over time But then of course, the risk is that you can have systemic anticoagulant effects due to release, especially if the heparin gets carried away in the bloodstream. You can have heparin mediated effects at off-site locations, which may not be very helpful. So, there is a small risk associated with that, with initiating systemic anticoagulant effects. You can also have heparin coating on the surface, but these are just physisorbed, then the adhesion and durability and activity of the coating needs to be carefully considered, especially when it comes to long-term performance. That becomes a question. And to sort of overcome those limitations, you can actually immobilize heparin onto surfaces through covalent grafting techniques, which ensures constant long-term stability. But then there the risk is, when you covalently bind the heparin, what happens to its conformation? Do you lose the active sites? Do the active sites get buried, or are they exposed? Because if you are covalently attaching and it is stable, but then the active sites get buried, that is of no use, right, because it is not going to bind antithrombin. So, that also has to be carefully looked into when you try and look at functionalizing heparin through immobilization. And two commercial examples that are very commonly seen are this trillium heparin bonded coatings for cardiopulmonary bypass, essentially heart-lung machines that take over the function of the heart and lung during heart surgery. So, the function of the heart is temporarily stopped to enable the surgeon to work more effectively on the heart, while there is a machine called the cardiopulmonary bypass machine, which temporarily takes over the role of the heart and the lung, and it oxygenates the blood, etc., and does what the heart and lung are supposed to do. And because the blood is going to directly come in contact with parts of this system, this trillium coating is used to prevent thrombosis. Essentially, it is non-leaching heparin covalently bonded to the surface to provide beneficial effects like heparin sulfate, which is anyway present in the vascular endothelium, and improve the biocompatibility of the blood contacting device. Essentially, do no harm, you are not creating a thrombus. In this case particularly, you are quote unquote tricking the blood into believing that it is coming into contact with the natural endothelium. So, the presence of PEG, and it is not just heparin, there is PEG, there is heparin, there is sulfonate groups, essentially a hydrophilic negatively charged surface that mimics the vascular endothelium. So, when the blood comes in contact with this surface that has been functionalized in this manner, it is tricked quote unquote into believing that this is the natural endothelium, and this minimizes protein adsorption and reduces thrombus formation, thus improving the biocompatibility. So, the biocompatibility here has to be connected to reduction in thrombus formation. The other is the Gore propatin vascular graft, which is again a covalently bound heparin, but the covalent binding happens only at one point, allowing the rest of the molecule to remain exposed for maintaining bioactivity and long-term stability without systemic anticoagulation effects. So, unlike the heparin releasing materials where there is a risk of systemic anticoagulant effects, and unlike covalent coatings that can change the conformation to an extent that the active sites do not get exposed, this claims to bind the heparin only at one point, allowing the rest of the molecule to remain active, but locally without having systemic anticoagulation effects. So, hopefully this gives you a good sense of the different strategies that are used for creating non-thrombogenic or antithrombogenic surfaces. And before we conclude, we will look at one quick pathological complication. It is somewhat related to the interactions and blood material interactions we have seen. So, it is good for us to look at it here, although this might seem like a digression. This is essentially calcification. Pathological calcification essentially has to do with the undesired formation of calcium phosphate nodules on the surface of implanted devices. And note that calcification, whether it is good or bad, is totally contextual. For example, if you are making bone implants, we have already seen osseointegration right, where now the material surface is conducive enough for new bone deposition, and bone is mineralized tissue. So, there is an inorganic matrix, namely the calcium phosphate or the hydroxyapatite like matrix associated with the organic collagen matrix in the bone extracellular matrix. So, in the case of bone, for example, calcification is beneficial, but calcification can be an extremely serious concern in heart valves, soft contact lenses, etc. And the consequences typically include interference with mechanical functioning for heart valves, for example, and opacity, for example, in the case of contact lenses. And of course, it is good to now pause and reflect on calcification and its role, whether it is good or bad again in the context of biocompatibility is totally contextual. Calcification in the context of osseointegration and bone tissue is beneficial, but pathological calcification of biomaterial surfaces is extremely detrimental. Now, there are factors that affect calcification, including structure and chemistry of the material, the host metabolic factors, particularly if they are young, the younger the patient, the more metabolically active they are, the higher the chance of calcification, and of course, the mechanical environment of the implant. Now, what is this and why does this happen? We have already seen what this is. This is the deposition of calcium phosphate nodules in biomaterial surfaces. Why it happens has to do with some of the mechanisms that we are looking at here. So, there is a bunch of reasons why this could happen. One is the cell membranes contain proteins with phosphorus groups, and when cells die, these calcium phosphate crystals can nucleate at material membrane interface at blood calcium levels are usually high. Again, this is why we are looking at it in the context of blood material interactions. Continued exposure of materials to blood can lead to calcification in broadly what you would call aging effects. So, this is not degradation, this is not deterioration, this is a change in properties. For example, we see that this can interfere with mechanical functioning of heart valves. So, change in properties or the transparency of the lens. So, a change in properties with time due to continued interactions. Because blood calcium levels are usually quite high, when cells die, these phosphorus groups can interact with the calcium in blood, and calcium phosphate crystals can nucleate at material membrane interfaces. The other reason why this can happen, and this is also commonly seen in tissues that are derived from animals, GTA is glutaraldehyde. Is typically used to preserve tissues such as porcine valves. So, one common replacement for a heart valve is if you do not want a mechanical valve, again this depends on the patient, the age of the patient, the functioning of the patient, the activity levels of the patient. But if a patient is prescribed a porcine valve, those are typically derived from a pig, and glutaraldehyde is used to preserve the tissue. But the glutaraldehyde may modify the phosphorus rich calcifiable structures in these bioprosthetic tissues, and that can and collagen, when it comes in contact with collagen, can serve as a template for crystal growth for these calcium phosphate, just as you would see in bone. In fact, in bone, the organization of the collagen is such that you can have calcium phosphate crystals nucleating and growing. Likewise, there it is beneficial. Here the same mechanism or a very similar mechanism is extremely detrimental. And another source due to aging, for example, you can have surface cracks in segmented polyurethanes which are used in insulating lead wires in pacemakers, for example. The surface cracks from oxidation due to aging effects can serve as sites for calcification. So, these are all mechanisms that are associated because of the interactions of the biomaterial surface with blood over a long period of time. Again, this is why we are looking at it under the theme of surfaces and interactions and under the topic of blood material interactions. And there are some very popular techniques widely used to treat and counter calcification. One is a very common technique is this bisphosphonate chelators that are FDA approved. You can also have ethanol treatment which extracts the phospholipids from glutaraldehyde treated samples such as the porcine valves. Or you can also have localized release of inhibitors of calcium phosphate formation, such as ions, positive cations, essentially iron and aluminum. So, these are all strategies that can be used to counter calcification. Now, the reason why we are looking at this, there are other pathological complications that can occur, such as tumor formation, etc. We are not going to look at those in any detail in this course, but this we are looking at primarily because of the interactions of blood, but this also serves as one representation of what can happen post implantation of a biomaterial. So, it is very important that there is continuous monitoring and surveillance. In fact, and we later look at translation and regulatory approvals. If you want to go through the full FDA approved and not just FDA cleared, post market surveillance is very critical. It is very important that patients are continually followed after implantation, but with particular attention being paid to some of these complications that can occur. For example, with drug eluting stents, it may seem like you have solved most of the problems, but if you have surfaces that do not re-endothelialize, then that can be an additional problem you have created. So, these are all aspects that have to be carefully balanced out from a materials design perspective, and as we go through this course, we will continuously keep looking at some of these aspects, so that you get a better sense of how complex these processes are and why it is very, very important to understand structure property function relationships for the effective design of biomaterials, particularly with regard to surface interactions.